Good morning, everybody. My name is Ian Galloway. I'm the director of the Center for Community Development Investments at the San Francisco Fed. And looking at the agenda, I just realized there's no break. I apologize for that. So if anybody needs to get up and use the restroom, we will not be offended. And there are doors on either side of the room. So we're running a little bit behind. So I'm going to skip the bios. The bios are all in your packet if you'd like to look up our distinguished speakers. But I will ask if we could just take one moment for all three of you to just very briefly introduce yourselves, and then we can jump into the discussion. So Sue, why don't you go ahead?
Okay, can you hear me now? I'm Sue Daugherty. I'm the CEO with MANNA.
Hi, I'm Ted Dallas. I'm a board member at MANNA.
Push the button.
Yes, sir.
I'm Bill George. I'm president and CEO of Health Partners Plans.
Great, thank you all. So Sue, I want to start with you actually. The origin of this conversation actually goes back to the HIV/AIDS crisis here in Philadelphia. Can you sort of take us back to that time and explain what role that played in the work then and continues to play today?
Sure. So MANNA is celebrating our 29th year as an organization. I joined the organization in 1999, I'd like to say at birth, as a registered dietitian, and have held several different positions. But it was really an interesting time in the organization when I joined. MANNA was founded during the HIV/AIDS crisis, and our 7 founding members really saw a need in the community to folks that were dying and dying alone and wanted to do something. And so they started to work by getting food donated from restaurants and providing comfort care to people with HIV and AIDS. And then certainly with the advancement of medication and, shortly after I joined the organization, we saw a tremendous shift, right around 1997, where folks were no longer dying quickly, but they were living, and certainly, though, not living without consequence. I often tell the story of when I was counseling a patient and saw a triglyceride level over 700. And, a normal one would be under 150. And I really thought, whoa, somebody screwed up, right? So I called the healthcare provider, was like, I don't know what lab you're using, but I don't know. This is not right. And the healthcare provider explained to me that it was an accurate number and that it was an unfortunate side effect from the HIV/AIDS medications. So kind of at the same time, I remember seeing the gooey mac and cheese coming out of the kitchen and realizing, we needed to shift a focus from helping people to die to helping people live. And so really in 1999 was when we said the science was born at MANNA. That's when we shifted our focus to providing the right nutrition and providing the right calories, micronutrients, macronutrients, helping people survive and win the fight against HIV and AIDS. And so we've certainly had many different progressions throughout the organization's history, but I would say key critical ones was in 2005 when we were going through a significant financial crisis. We made the pretty bold decision, the board of directors and the leadership at the time, to not only expand beyond HIV and AIDS, so we were going to become no longer disease specific. Today we serve all illnesses, but we also believed in the power of food as medicine. And so you don't prescribe a prescription to someone and say, I'm going to give you that prescription, Monday through Friday, and you figure it out on the weekend. So we took very serious the role of nutrition and the role of treatment that nutrition has in health. And we moved from a supplemental program to a complete meal program. So providing 3 meals a day, 7 days a week. We kind of see ourselves as the pharmacy for your prescription diet. And today we've touched over 85 different illnesses. And we're providing about 1.3 million meals a year to about 1,300 individuals daily.
Thanks, Sue. So Bill, can you maybe round out the rest of the chronic disease landscape here in the Philadelphia region? Obviously, it sounds like the focus here has expanded beyond HIV/AIDS, but what are some of the other areas that you're particularly interested in?
Sure. As I said earlier, I represent Health Partners Plans. We are a licensed insurance company, a health maintenance organization. We deal with people through government-funded programs, but the health issues that we deal with are heart disease, cancer, cerebrovascular disease, chronic respiratory issues, chronic kidney disease, and lastly, diabetes. And we are, for whatever reason, we got this, the plan of choice for diabetics. And we take all comers. We deal predominantly with people in North Philadelphia. And if you're from Philadelphia or not, on a per capita basis, North Philadelphia is probably one of the poorest communities on a per capita basis in the United States. The population is ethnically and racially diverse. The education that we deal with is traditionally fourth grade reading levels. We face people with enormous challenges and social determinants that are impacting their abilities to get care as well as manage their own disease. Answer your question?
It did. Ted, is there anything you'd like to add to round out that landscape?
I can give a perspective from in a previous life. I first got to meet Sue. I was the Secretary for Human Services for Pennsylvania, and in that job, you meet a lot of nonprofit providers and folks who tell a good story. But I think the thing that Sue got to that really caught my attention was finding that way to get to a better outcome for folks in a way that makes sense and is sustainable, right? So part of my job in my old life was managing the Medicaid system in Pennsylvania, right? And when you look at Medicaid or you look at any kind of healthcare system, you probably have about 1% of the population driving maybe 20% of your cost, and 5% might drive 50% of your cost, right? So those folks who are the most complex, the folks who have the most difficult to solve issues are the ones driving all the cost, right? And everybody in this room pays for them, right? So as the healthcare system costs more money, your health insurance is largely, that's what health insurance is, right? You pay for sick people to get better, and you do that because you're worried you might be a sick person one day, right? So as you're making that investment, everybody in this room is paying for that. And for those folks in those chronic conditions and those complicated conditions, right, there's some people that we can't do a whole lot about. So if you look at the top 25 folks, there are folks in there who are hemophiliacs, for example, right? And that is an issue where the cost of their care is just high. It's just one of those things. But there are chronic conditions and complex conditions, and folks who have complex conditions who also have chronic conditions, they're the ones who drive the cost. What MANNA gets to is a way that you can actually start to move in and get good results for those folks that free up resources throughout the entire healthcare system, but most importantly, have an impact on those people's quality of life, which right now, if you look at the way their life goes, is not that great. So as we talk a little bit more, I think we'll get into how MANNA's solution gets to a place where you can, in a very reasonable way, in a very human way, you can start to get into that cost and start making a difference in those people's lives.
So Sue, Ted makes a really interesting point about you have to know what the target population is. We're measuring both care utilization for that population and also costs borne by that population. How did you know that what you do at MANNA really makes an impact with that group of people? Did you go through a evaluation process? How were you able to sort of frame your work in terms that would clearly address some of those chronic diseases affecting those superutilizers of care?
Sure. So I could probably spend hours answering that question, but for many, many, many years, we were tracking a lot of outputs, right? How many individuals are we serving? How many meals are we pumping out? We were always honestly tracking nutritional indicators, right? So tracking weight status and tracking body mass index and so forth. But we just could never get recognized as part of treatment, right? We were kind of looked at like, oh, you're that nice nonprofit. You're doing, nice work. And we're like, no, we're doing like critical work where you're prescribing diets and people don't have access to that. And so really it was after many, many years of frustration that we said, okay, we need to prove it. We need to prove what is our impact on health outcomes and on health cost. And so we went to our board of directors in 2010 and we said, we want to do research and we want to study this. And again, I mentioned the financial crisis in 2005. Things weren't looking so much better in 2010 either. And that we knew that the investment to do this research was going to cost the organization about $135,000, which is a lot of money. And so after really pitching it and explaining to the board, and certainly we have buy-in from leadership and buy-in from the staff, the board went ahead and approved that if necessary, MANNA would fund it. We are thankful we actually received funding to fund the research, but we made the decision. Now, I want to mention that none of us at MANNA are researchers, right? So this was like new territory for us. And so that started in 2010. We partnered with a local Medicaid managed MCO that was going to provide us this statistical analysis. We partnered with a research team, and it was many, many years. But we were thrilled that the research that was published in the Journal of Primary Care and Community Health showed that by providing nutrition education and medically tailored meals, 21 meals a week, not only had significant impact on health outcomes, but saved significant healthcare cost, a significant reduction in healthcare costs. So that was really what armed us with the data to say, hey, we're not that nice to have. We're a must-have program. We're providing critical care to people. And we certainly found through that research that where we were having our greatest impact was with the population that Ted was just mentioning, the super utilizers, right? We don't have a financial criteria at MANNA, but the reality is there are 95% of the population we serve fall well below poverty. And I say all the time, right? I don't think anyone chooses to be unhealthy, right? I don't think people wake up and they want to be unhealthy. People just don't have access. And so certainly at the foundation of what MANNA does is we want to just take care of people, and we want to provide people the tools and give them access to proper nutrition for critical periods in their illness.
So, Bill, when Sue knocked on your door, and I can visualize this, she's got her report in her hand proving that MANNA is producing enormous value to the healthcare system. Was the partnership obvious at that point, or did it take some further conversations? And then, sort of a second part question to that: having now been part of this for years, do you feel like the promise has been borne out in the outcomes?
Okay. Actually, I'd like to say that it was more of a serendipitous connection between our two organizations, and Ann Hoskins Brown, who was sitting there in the audience, invited me to an open house, and was frankly enjoying wonderful homemade cookies that I couldn't believe didn't have chocolate in them, and coffee, and hearing about MANNA and what they could do. But on the other hand, in my own personal life, I have firsthand knowledge of the linkage between managing your diet well and successfully managing type 1 diabetes. And if I could see that managing your diet well meant that you managed the diabetes versus it managing you. I also, as I said earlier, Health Partners Plans is the plan of choice for diabetics. I know that we have thousands of diabetics, and a number of them are very fragile and who are literally unable or unwilling to manage their diet. So they are regularly, predictably being admitted to hospitals for acute stays that cost tens of thousands of dollars, that I'm sure are extremely disruptive to their families. If they're not in the hospital, they're being admitted to emergency rooms at great cost to our organization and ultimately to taxpayers. So it wasn't a real big sell. I'm an accountant by trade. I had never found an organization that said that they could provide medically tailored meals. And I asked a very simple question: can you provide a meal that's appropriate for a diabetic? And the answer was very simply yes. And I said, you have a partner. So it took off. And we initially started with about 30 members, but we saw that the cost of care dropped. We were sustaining about a 20% drop in costs. The satisfaction of our members has taken off, and we've expanded it beyond diabetes. Now, we are not a research company. I shudder when I'm asked to share results because we don't have this model that has all these statistics to say you're a candidate, you're not a candidate. It's very much of a clinical call. And the question is the member ready for change? And if the member is not ready for change, to have a restricted diet and to have, I would call it an obtrusive series of phone calls. I would never call your nutritionist obtrusive, but we're going to be on the phone asking you questions. Are you managing your diet? How are your numbers? And if you don't want to change your behavior, it's a waste of time for you, and it's a waste of our money at this point. So it's not this double-blinded survey with samples, and we pick candidates and we run with it. And we've saved a lot of money. So we couldn't be happier. And my regret is that we didn't meet the MANNA folks years ago.
Ditto.
So we had a planning call before for this panel, and I was just fascinated to hear about your sort of shift towards an outcomes orientation, and that being a critical sort of variable in your success. I think this came up earlier. A lot of nonprofits are doing great work. A lot of nonprofits believe in their heart of hearts that they are achieving the outcomes that their mission is encouraging them to pursue. But they don't necessarily have an outcomes orientation. And that's a really important distinction. And so Sue and Ted, I'd love to hear your perspective as a board member as well. Can you kind of talk about what that took from an internal culture standpoint? And was it a seamless transition? Was it a difficult transition? How did you make the case internally to your staff that this was going to fundamentally change the way that you did your work and that it was worth it?
I wouldn't say easy. I think, and certainly, there's that culture in a community-based organization, right? That some people felt like, it doesn't matter. We have to do what we need to do. And this is our mission, and this is what we're serving, and this is who we're serving and why we're serving. And, there was always the question of, well, what if the data doesn't show any change? Right. And my answer to that was then we will change, right? We need to be doing things that are having improvement in the population that we're serving. So certainly with the board, I think, to some extent, I think actually not being in a great financial position was helpful, because I think it was really telling. I mean, there were literally days that I did not know if the organization would survive. I remember in 2006 being asked by our director of finance, do I need to be paid on Friday? And being like, yes, I do. And so, but I do think that, MANNA historically has been an organization that has been bold enough to stay true to the mission, right? And we do, and I think Ted can talk about, we start every board meeting with having a moment of a client impact, a client story. And, there's many different directions we could have gone that were tempting at times, but I think staying true to the mission. And I think at that time, being in that financial crisis, I think the board and the leadership knew we needed to do something.
So I think the way I can probably best answer that question is talk about the first time I met Sue.
Yeah.
I met with her. It was day I was in Philadelphia. I was thankfully out of Harrisburg, right? And it was one of many meetings I had. And when you have that job, you meet with provider after provider, and every provider tells you a story about, well, the demand is so great for what we're doing, we need more money, right? Or everyone says the need, we served 1 million meals last year, and now we serve 1.5 million meals. We need more money, right? And you hear a lot of those things, and they all kind of, honestly, sometimes they just sort of wash together, right? Because you're saying, okay, great, I understand that, but there are 8 different people who I'm going to meet with later today who are going to tell me the same thing, right? So I think the mindset and the change that really caught my attention was Sue was talking about, and Ann, don't forget Ann, Sue and Ann were talking about the impact that it had and the change that it had in the system. And there's a mindset that's in, and you were talking about mindset, there's a mindset among payers, whether it's Medicaid or the healthcare system, there's a mindset among providers, and it's all about we have to serve more people, we have to be able to pay our bills, we have to do all that shift. And what Sue and Ann talked about that day was the impact they have on people's lives, and the financial impact, but also the human impact, right? And where a system that is always seems to be headed towards a more complicated medical model, one that costs more money, Sue and Ann said, well, there's a simple thing you can do. You can get people to eat right. And when they eat right and we make sure that they're getting the nutrition they need, that can have a bigger impact sometimes on their health than the most complicated medical things that we can do. And it's also cheaper. That got my attention. That's one of the things that made me really fall in love with MANNA. It makes me proud to be a board member, is that they're making that change by getting to a place where they're making that intervention early on, and they're getting it to a place where it's a manageable thing, and it's in a way that helps people take control of their own life.
So Ted, I want to stay with you. Sort of a similar question. When you were director of the Department of Human Services, I imagine that there was a culture shift that needed to happen on your team too, and with your staff. Can you sort of reflect on the types of changes that you needed to make, or the team that you needed to assemble, or the case that you needed to make to make this all a little bit easier than it is, given the status quo?
So I said to Shakima earlier when we were talking before the event started, was I think that the government almost perfectly makes it almost completely impossible to do the right thing, but we make it just so that if you do the impossible, you might be able to do a little bit, right? So part of it is it starts with, and a lot of it's driven by money comes in a certain way in government, and when you get the money, a lot of times it comes from the federal government and strings are attached, right? And that leads to certain ways of thinking. So there were things that you had to start thinking about different things. So when I first met with folks within the department, when I first got there, they started saying things to me like, well, we serve this many people. Okay, great. And we're serving this many more. Okay, good. But what are we getting for the results, right? And then there were sort of micro changes too. When I first got there, people said to me, we had this many cases. We had that many cases. I said, no, you don't have cases. You have people. You have human beings, right, who need to have that outcome, right? And that shift and that change leads to thinking about something like MANNA, right? So Sue mentioned that most of the folks they serve are through Medicaid, right? Medicaid is a per capita system, right? It's a per member per month fee, right? Number of people you serve, you get a certain amount of money to do it, and managed care companies manage that. And that allows for some flexibility, but it also gets you thinking a certain way, right? So sometimes they say, well, I have this many costs and I only have this amount of money, so I'm doing the best I can. But with that money coming in by the number of people you serve, it makes people say, I need to serve more people because that way I'll have more money. The shift you have to make is, who are the folks that are driving that cost? Who are the folks that are having the worst health outcomes? Focusing on them, that's the way that you're going to free up those resources. That's the way you're going to be able to have that impact, and thinking about those things in a different way. So that was everyone from the Medicaid director to folks in the governor's office, but getting people to think about it that different way and saying that getting those outcomes are not going to cost you more money. Getting you those outcomes and thinking about the way are actually going to save you money.
So this is an inspiring example, and I just have to assume it can't be this easy, right? There have to be some things that are hard when you operationalize a partnership like this. Can you speak to some of them? And this is to any of you or all of you, to some of those challenges of taking a great idea and actually putting it into practice on a day-to-day basis. Some things that really stand out to you. And anyone who wants to jump in.
I think there are a number of critical steps, and first you need the leadership at the top to convincingly say to everyone in the organization that this is his or her priority, and in addition, that their priority has to be linked with his or her priority, and then make sure that they have the resources to get this done. But at the same time, identify every entity provider that has an impact on them and work with them to give them data that they can see what they're doing well and what they're not doing well, and give them the actionable data that they can fix it. So we give providers data indicating what members need to be seen for colonoscopies so that they can go and get them. We'll give them phone numbers. We'll help them make phone calls. If you're trying to improve the percentage of members who need colonoscopies, for instance, giving incentives to members so that they'll get them. And ultimately, we put someone in charge of each health outcome. And so someone is staying up at night worrying about pregnant moms getting seen in the first 3 months, moms getting examined for depression after delivery. Needs someone to be looking at that every day. And it's a comprehensive program that everyone involved knows their roles and they'd have information. And they know that it's important from the top.
And Bill is being kind by not mentioning how patient his team was with working with MANNA, right? So as he mentioned, he came to MANNA because a colleague of mine, Ann, invited him, and they had known each other. They were friendly. And so he came, he saw the data. He asked if we could do diabetic meals. We said yes. And he was like, okay, you have a partnership. And I was like, yeah, I've heard that before, right? Like, honestly, I remember Ann telling me, I was like, yeah, that's great, but it always falls apart when we sit at the table and say, how are we going to do this? But within 48 hours, Bill had us at a meeting with his entire team. And we sat at that table, and it was a year. It was a process over a year. It truly is. We are not a vendor. I would say we are a true partner with Health Partners plans. And really, that's because of the tremendous work that their team did to support us, right? Electronic billing. We didn't know what that was. What do you mean we have to do electronic billing? So we certainly had to shift organizationally, and without the patience and the guidance of their team and Health Partners plans, it would have been a much more difficult process. But they really did kind of help us walk through. We certainly, as an organization, knew that we would do anything, to make this possible. But it was, we had to hire a electronic medical biller, right? And that was a cost. We had HIPAA, a whole new world with HIPAA, right? We thought we were HIPAA compliant, but, we had to invest a lot to be HIPAA compliant. And so it certainly was a process. And I certainly give a tremendous amount of credit to Ted for his role at the state level at that time, that really the buy-in from the state, you have no idea the impact that had. When the state listed our partnership with Health Partners Plans as an innovative partnership. And I can't tell you how many doors that opened, and being invited to present at the medical directors meeting at the state in Harrisburg. So it certainly was a process and a lot of buy-in to go through that.
I would add I agree with both Sue and Bill here, but I would add one other factor, and that is risk, right? And you have to be not afraid to fail, right? So a lot of our jobs and a lot of people, we go through our lives and we're worried about, if we do this and it doesn't work, what's going to happen? Am I going to lose my job? Is MANNA going to fold if we make a bet on this, and so on? Part of it is you have to have an ability to embrace that risk and be willing to take it, and find folks who are willing to do that. So I'll give one non-MANNA example, right? Is in my day job now, work for a human services provider. We do a bunch of stuff, but one of the things we do is we operate probably one of the largest drug and alcohol clinics in Philadelphia, right? You see over 700 people a day. The opioid crisis, everyone in this room knows about it, right? In that world, because the way we got paid, right? Those 700 people are climbing. We were losing tons and tons of money, right? We were hundreds of thousands of dollars, right? We were able to do that because it's a large organization. But in that world, we couldn't do it forever, right? So we went to our funder and we said, we can't do it this way. And also, the way you're paying us, the way they would pay us is they paid us per hour of therapy. So what do you think we did, right? More and more therapy, right? Regardless of whether or not it was actually helping people get into recovery or not, right? So, and the quality wasn't good. And even despite the fact that we had more and more people and more hours, we were crashing and burning. So we said, okay, can you work with us? And can you pay us for each of the people we serve? And then we want to get to the outcomes for those folks. And they said, we could, but what are the outcomes? And the answer was, we don't know yet, right? But I can tell you that if we get there, we'll have the space to be able, if we're getting paid for each person we serve instead of the number of hours of therapy, we can make changes like one-on-one therapy. We can, instead of group therapy, we can put a center in for people who have kids to have their kids there while they're going through therapy. We can have a workforce development provider in there who help them find a job when they're getting into recovery. We can do all those things if you just change the way we pay, and we can get to things that are better. And they said, after begging, pleading, and other things, right? They said, okay, right? And in the couple of months since we've done that, we are no longer losing our shirts. Our engagement of people in therapy has gone way up. It's now above the national average, and we're not putting people through a baton death march of longer and longer therapy hours, and we're getting better results. So that is that change. But in order to do that, our funder right now is taking a risk because we don't have agreed upon service measures that are going to show them savings and so on and so on. But as a partner with us, they're taking that risk. Sue took that risk and Bill took that risk when they first did that partnership. I think it's paid off for them, right? But you have to be able to take that risk, because if you don't, you're going to be funding things the way that you're funding things forever and ever.
So I think that's a incredibly important point, and actually takes me to my next question. I think obviously value-based purchasing agreements, risk-sharing agreements, some of these new policy tools that are available post-ACA have opened up a potentially new world of paying for community-based organizations and the work that they do. But it's a bit of a Pandora's box, and there are challenges associated with that approach. I think it's exciting in a lot of ways, but I'm curious how you all feel about this. Is this sort of the next frontier for this partnership between organizations that can contribute to the social determinants of health and the healthcare system, or is more of a traditional arrangement as it currently exists sort of a better fit? And I know that's sort of a broad question, but I think you all bring unique perspective to answering it. So I'd be curious, and maybe Bill, we'll start with you.
Well, I think just want to recall what Ted said, is that so much of what we do in healthcare is by unit of service. So Ted's organization was given incentive to bill, and they reacted, and they billed, and the outcomes were not. They were bad.
Yeah.
Okay.
I'm subtle like that.
And so the issue is is getting value, and this is really, really messy, because on one hand, as an insurance company, we are routinely approached by organizations saying that they have found, for instance, the key to managing people with a COPD, chronic obstructive pulmonary disease. They got this iPad, which was venture capital financed, and the link put this in someone's home. And you give them this iPad, and it'll reduce the cost dramatically and improve health outcomes. And you say, gee, that sounds really great. But at the same time, I have an army, bad choice of words, but I have a lot of people who are clinicians who are trying to help these people in disease management programs. They're regularly seeing their doctor, or maybe they aren't seeing their doctor. They're taking pills. They're managing their own condition. So how do you tease out what had the impact? And if so, how much of the impact? And that is fundamentally very, very difficult. And I'm a recovering CPA, so I look at things pretty simply. Mm-hmm. And if I gave you 50 people's lives to manage, I want to see at the end of the day, for those specific 50 people, did the cost go down? Don't talk to me about whole populations of people with COPD. No, I gave you 50 specific people. Did their health outcomes improve? And lots of vendors will say, no, do it the whole population. So it becomes very, very messy. It's a negotiation, and I mean this respectfully that if Sue and I had to prove a we never would have started this program. Never would have gotten off the ground. But I do think this is a key to improving the health outcomes in the United States, whether you're a pharmaceutical company or a surgeon, and if the outcomes aren't well with a surgery, you should be compelled to fix it. End the discussion and not get extra money. I think that on the other hand, providers are jumping into this and they don't know what they're getting into. And I think ultimately a lot of people are going to be very unhappy in that they took a risk for something and they couldn't deliver and they didn't get the money. So I think we've got to work through this. But this is a very difficult negotiation between parties. I'll stop talking at this point.
Yeah, I'm wondering from the provider side of the transaction, how do you feel about sort of reorienting the payment streams to pay you for delivering an outcome as opposed to delivering a service? Is that exciting? Is that terrifying? Some combination?
Probably some combination. I think, and I'm not a finance person, and I sometimes feel like there's this cycle of care, right? And that, to me, we need to break this. Okay, we're going to do something for this person for X number of time and then see the impact, whether that's through a value-based cost savings or through a health metric outcome. But then it's like, okay, then what? Right. And so we were, so much of this morning's conversation has been about poverty, and the folks that I think we're all talking about often, poverty is an underlying cause. And so I think that we need to look at, I get lost in the terminology and just focused on taking care of people and taking care of people as long as necessary to get them out of the cycle. And that's not certainly just through nutrition. And, certainly since we've been doing this and we've gotten a lot of attention nationally, there's a lot more competition, right, in the field of medically tailored meals. And the big difference, though, is they are for profit and we are not. And so, to me, and certainly I think Ted would support this as a board member, MANNA is not sitting around the table thinking about, how much money can we stock away and put into the investment accounts and so forth. We're sitting around the table talking about how can we take care of more people? How do we get access to everyone who needs this service? And so whether that comes through a value-based payment or paying for true cost, right? That is what will have the greatest impact on the organization.
So I think value-based payments is something that everyone talks about in healthcare now, and everyone talks about it, but for the life of me, I don't know actually what they are just yet, right? So I do know that there are better ones and ones that are worse. Right? A bad one is provider gets paid $100, right? And then the payer says, okay, I'm going to pay you $80, and if you hit certain targets, I'll give you the $20 back, and you'll be back at $100, right? And that's one way funders can do that, right? And that is one way to do it, but not a good one. A better one is, okay, you make $100 now, I'm going to give you 90, and if you hit certain goals, you can get the 10 back. But if you really perform well and you get to those outcomes that save the funder money and get to better outcomes for folks, I'll give you $120 because I'm going to be saving more than $20 when you do it. Mm-hmm. Getting folks along that, and it comes back to risk I mentioned earlier, getting folks to do that is a challenge, right? Because, Bill, you have tight margins. Everyone has, tight margins throughout the healthcare system. But part of it is taking that chance, right? So, and I think it's a little more complicated for MANNA because MANNA is one intervention in the system. There are a lot of other things that can impact that person's health, right? So if I were in my old job, I would say, oh yeah, we got to do value-based purchasing. But if I'm on the MANNA board, I would say, okay, you're going to hold me responsible for things that people are doing outside of the care I provide. And that is when Bill's talking about being a tricky thing. And I think the only way you get there is, what I would advocate for MANNA if they were going to go down that route is let's do the intervention for 1 year or whatever the time period is and get paid the same way that we did before. And then we can see what the impact is, right? And then we can figure out what that is. Then maybe you can start doing it because Bill's right. There are a bunch of people who are, probably leaping headlong into a value-based payment. And, they're like, I'm going to leap tall buildings in a single bound and I'm going to do all this stuff. And then when they find out it's a lot more complicated, they could take a real hit for that. And then people say, well, I'm never going to do a value-based payment again. Yeah. So I think part of it is finding ways to get an experiment and do that before that risk is shared, but that the risk is shared equally.
It's funny. I think I've done some research on pay for success over the years, and I think when the history of pay for success and social impact bonds is written, that's going to be part of the conversation. There are some jurisdictions around the country who tried this and got a little bit over their skis, and now they're gun shy, and they're not going to do it again. And I think we just need to be really careful about how we implement these kinds of partnerships and funding models and do it in an incremental way. So I think that's a really, really important point. I want to leave plenty of time for questions. So just one really quick lightning round here, sort of lessons learned question. Very, very briefly, if you can. One thing you're really, really happy that you did in hindsight, and one thing that if you could do it again, you would do it differently. Bill,
well, I can add a different dimension. I'm retiring in 6 days.
Wow. We got you just under the wire.
If I could have done it all over again, in addition to dealing with physical health issues like diabetes and hypertension and whatnot, I think there's a growing body of evidence under behavioral health that a good diet can help manage and alleviate the horrible pressures of depression and anxiety. And you say, well, where's the savings? The savings is the enormous amount of money that we are spending on psychotropic drugs, the enormous cost to society of people taking their own lives because they can't deal with their depression, the cost of treatment, and giving people good and nutritious food, whether it's vegetables or fruits. And apparently they've also, studies indicate that, and I'll stop in a second, that if you eat canned fruit, it has no value in this regard. So I think there's some enormous benefits here, and it would have been neat to partner with both MANNA and some behavioral health providers to see what we could do. And I'm going to have to leave that to my successor to try. But I'm very, very happy otherwise in terms of what we did. And as I said, wish we had met you a long, long time ago, Sue.
I think in terms of the history of MANNA, I think probably what I would say I'm most proud of in the organization's history is the decision to become a complete meal program. I think if we had not made that decision, I don't think we would be sitting here and having these conversations, because there would be such a variable, right? And what we hear from our population over and over again, the clients, is the fact that we are providing them breakfast, lunch, and dinner, 3 meals a day, 7 days a week, very structured. They don't have to think about, okay, well, if I'm eating this for breakfast, what am I supposed to be eating for dinner? We take away, to Bill's comments he just was mentioning, the anxiety, right? I can't tell you, as a dietitian, when I was counseling patients for years and years and years, and I would have my food models, right? And I'd be like, this is the size of an orange you're supposed to eat, and this is the right size protein. And I knew that they were going home. They didn't have access to any of that. And so the education that we're able to provide through the education component, but then the product, right? The deliverable and the long-term impact that has on our client population. They're like, wow, I had no idea that's what breakfast is supposed to look like, or that's the size of, chicken I'm supposed to be eating. So that, I think, is probably, I think, one of the most critical decisions and impactful decisions the organization has made. And I would say, if I could do it over again, I would, data research sooner. I mean, it's really through the partnerships with the insurance contracts is that, we've been having success, right? And then, I sit down at the table and I'm like, hey, Bill, we're having all this great success. Why aren't we doing more of this? And it's because there's not data. And so MANNA just launched this past March, the MANNA Institute, which is a research and evaluation arm of MANNA, because unfortunately in the world of medically tailored nutritious meals, there's not any impact on, what does that mean for wound care? What does that mean for dialysis? People don't think twice about prescribing 2,000 cc fluid restriction, 4-gram potassium, 4-gram phosphorus, mechanical soft diet. But what does that mean, and what is the impact? So more data.
So I think the thing I'm probably most happy about was that I agreed to meet with Sue and got to know her and Anne and MANNA. That I did decide to go to that meeting. But I think not a big one for what I would have done differently or regret. But I just follow up on something Bill said. I think if I did have a regret, it would be that when we first started thinking about this, it was just when we thought about people's health, we thought about diabetes, hypertension, and physical health, right? And I think Bill's 100% right about looking at people's complete health and their behavioral health, right? So one of the things that Sue and I have been talking about are if you take folks with serious mental illness, SMI, right? They have a life expectancy that is 25 years shorter than the average person. 25 years, right? They don't die from mental illness. They die from about 2/3 of them have a chronic condition, right? That affects their health. And because of their behavioral health issues or their SMI, they don't handle and treat those issues, diabetes, hypertension, right? And in the richest country in the world, not being able to manage that better and not thinking about it that way, it's criminal at the end of the day, right? So my hope is that we can convince, people who have my job now and foundations and very many fine folks that we like very much who have a lot of money, right? To fund looking at that and looking at behavioral health at the same time and saying a person is not, right? A human being is not their physical health problems and their behavioral health problems, right? They shouldn't be funded separately. They shouldn't be, they shouldn't be looked at differently. They shouldn't be, you go over here for your physical health, you go over here for your behavioral health, you go over here for your nutrition. It's that sort of integrated approach. And we're going to do the research, hopefully, right? But I don't need the research. And everyone in here knows the answer. The answer is if we're intervening, if we're having that right intervention at that right time, we're giving them a medically tailored meal, we're making sure they're getting the care they need, that 25 years is going to get a lot smaller, right? So that, I don't know if I want to do it over again, but that's what I want to do next.
There's a great story in the book, in a chapter written by Carol Naughton, who's the president of Purpose-Built Communities, which is a national model, neighborhood scale, comprehensive community development. And the first iteration of that model was a neighborhood called Eastlake. And when they started, and this was in the 90s, and I think if they'd known about MANNA, they would have called you. But they had a significant childhood obesity challenge with a lot of the kids who lived in the neighborhood. But they were unprepared. They didn't know how to deal with that particular issue. So they actually didn't implement any anti-obesity programming, or healthy meals or any of the things that would have really directly addressed that challenge. They figured it was something they could get to after they dealt with the housing and the education and the wraparound services. And what they found after a couple years, is that by addressing all of those neighborhood factors, by reducing the toxic stress that these kids were otherwise being exposed to, the obesity rate dropped to 0. And it's just a really interesting example of this relationship between behavioral health, mental health, and physical health. It's everything. It's got to be everything at the same time. And we need to stop sort of treating them as separate silos, and certainly stop paying for it in separate silos, because that's not going to solve the fundamental drivers of poor health. So we have about 20 minutes of time for audience Q&A. Any questions for the panel? And if we have speakers that were here earlier in the day, I think we can direct questions to them as well. Don't all jump at once. Yes.
Hello. I will remind that all of us in here are really into this topic. So we are on board with the fact that social determinants of health and giving people access to healthy opportunities is probably the solution that we need to be gunning for. That said, there is a lot of risk involved with that because of the lack of data and because of, things just haven't been tried. And there are people who may be skeptical, either politically, ideologically, for any reason. Did you guys receive any pushback whatsoever And how did you overcome that with education discussions, or what can other people do to think about, bringing more people on in this conversation who aren't already sitting in this room?
I can just quickly say organizationally that I would say, so MANNA is a volunteer-driven organization. We have about a staff of 40, but we have over 7,000 volunteers, so over like 150 volunteers a day. So I would say that the volunteer reaction initially when we started to talk about our partnerships with insurance and fee-for-service structure, there was a lot of explaining, to do. There was people that were so concerned that, MANNA was walking away from serving those in most need. And the reality is that, the folks that we're serving through our contract relationships are those in most need. And so just doing a lot of education, reminding that, every meal is paid for somehow through the organization. Today we're serving 1,300 individuals, about 1,000 we're serving through philanthropic support, and 300 through fee-for-service reimbursement. But that, I would say as a community-based organization and starting to have this conversation, we needed to have town hall meetings with the volunteers and just reminding the volunteers we're not doing something different. We're not walking away from our client base.
So one thing I would add to that is, I had the pleasure of testifying many times in front of the General Assembly, right? So folks who were, folks from all over Pennsylvania who were, maybe they were a little skeptical of some of the things we said, right? And a lot of them would say, and some of them didn't care, right? But some of them would say, that's nice, but everybody needs something, and there are families out there who don't get any support. Why should my constituents care? Or they would say we can't afford it, right? And my response to that was always, that presumes that you're not already paying for it, right? You are, right? Everybody is already paying for it, right? You can pay, and I would say to them, you can pay $30,000, $40,000 a year to lock somebody up, or you can spend a couple $1,000s when they're a kid and do some early childhood intervention and keep them from going to jail in the first place. Either way, you're going to be spending the money. Which way do you want to do it, right? And I think ultimately, they're the folks of goodwill in this room who care about those outcomes, but part of crafting the messages for the people who don't care or don't think about it every day. And part of it is what's in it for them. And to me, what's in it for them is, as a society and as an individual, we are all paying for the dysfunction of the healthcare system, right? And if people are under the impression that not making that investment and not thinking that way is going to save them money, my argument is it's actually costing money to do this. And because we do everything backwards and we fund things when people are at their worst and it costs the most money, that means you don't have money in your wallet to go out to the movies, or you don't have the ability to get new sneakers for your kids because you're already paying for these things one way or another. So to me, for the folks who do care, I think there's a very solid argument. For the folks who don't, it's you're already paying for it one way or another. So we can either be dumb about the way we spend money, or we can do it a smart way. It's up to us at the end of the day.
I think people use the absence of data as a neat excuse not to do something. And I think Ted used the phrase, you get to give people permission to fail. We're a small insurance company, but we're a large company. We're about $2 billion in premium. And I give people the chance and permission to fail. I will try anything. And when we can't figure out which is the best route, we'll try maybe three things. For instance, we have people who are chronically unable to take their prescriptions when they're supposed to. Sounds real simple, but if you have 15 a day you're supposed to take, that's a difficult task. And then when you empty out the bottle, they don't do anything. So there are automated medicine cabinets that have voices that say, take your pill. And they're linked into our offices when someone doesn't take the pill. And when the pill bottle is emptied, we get a message and we call a pharmacy. Okay. We're investing with 3 different companies. We have no data, putting these automated electronic medicine cabinets in people's homes. Why not? They are chronically admitted to hospitals for overnight long-term admissions, ER visits. If you don't do anything, it's only going to get worse. So we're trying. You can't do nothing. So we have no data. And at the end of the day, 6 months from now, we'll pick one of the 3 vendors, or maybe we'll just continue with the 3 and continue expanding this thing out. That's all like MANNA. I really don't need the data. After we went beyond diabetes, let's keep trying to see other conditions. Because if you do nothing, things generally get worse.
Hi, my name is Teresa Lee. I'm with an organization called the Visiting Nurse Association Health Group. And we're mostly in central and northern Jersey, so a little outside of this Philly region. It's great to see so many folks from the Philadelphia area. We're sort of a unique organization. We provide a lot of home and community-based services, both in terms of, serving the elderly with home health and hospice, but then also at the early education and younger end of the spectrum. We're in NFP, parents. We do a lot with WIC and, I'll just say we run 19 different programs for children and family health. We have an FQHC. New Jersey is a unique state, just as Pennsylvania is a unique state. We have a lot of challenges working with payers. And I'm really excited to hear about this conversation. We're interested in serving the social determinants of health, but what we see is a lot of fragmentation. There are just so many different programs with separate regulatory structures and very little investment in information sharing. We've been trying to invest in information sharing because of those individual program silos, we can't even talk to ourselves sometimes. So we've been fortunate. We've got funding from the Nicholson Foundation to invest in, IT infrastructure. It's a huge project. Anyway, it's a long way of saying, I think it's really terrific, this partnership I'm hearing about between MANNA and it sounds like a Medicaid managed care plan. I'm wondering if you've been thinking, even bigger about, sort of interactions with other types of providers that are already being funded by government and sort of the complexity of weaving it together and reducing fragmentation further.
So I can start with that. I was going on and on about behavioral health, right? So Pennsylvania, one of the unique parts of Pennsylvania is there are, in the Medicaid system, there are physical health MCOs and there are behavioral health MCOs, right? And they have different funding and they work differently. So there's the coordination problem. If the idea that we're talking about that medically tailored meals can help people with behavioral health issues too, right? One of the things we're going to have to figure out is, okay, there's a benefit on the physical health side, right? Especially if we're going to do a value-based contract or an outcome-based contract. There's a benefit on the physical health side and there's a benefit on the behavioral health side. But you have two different organizations with two different sets of missions and they serve the same people in many cases, but they may not even know they do, right? So part of that, the biggest challenge is going to be, and getting back to, if I'm Sue, how am I going to do a value-based contract when it's that fragmented and that complicated? Part of it's going to have to be getting the physical health and the behavioral health folks together and say, you're both going to benefit, right? So there both should be value that you can bring to the table. And that's getting people who don't usually work together to work together, right? And getting folks to think about things a different way. So it's a very complicated thing, but it's going to happen. And all that comes from government. In this case, government is the primary fund. That money all comes in certain ways, and it comes based on Pennsylvania gets money based on the number of people they have who are getting Medicaid, based on the poverty rate, but they don't get money based on how good or bad we are at actually delivering services, right? So you have all the incentives messed up, but the challenge is how do you get the MCOs or get the government to realize that value and change the way they're going to make that payment, right?
I'd like to key in on one point that you made that drives me crazy, and that is the issues surrounding the sharing of data. And I appreciate how important it is to protect people's privacy, in particular people who have certain conditions that deserve special protections, whether they have mental health issues, drug and alcohol issues. But there are super restrictions around the sharing of this data. And naively, I'd like to suggest, and this is probably the worst possible time to bring it up, when everyone is screaming about Facebook and Google and using facial recognition and people's privacy being violated by, I don't know, Instagram, what all this social network stuff, that we need to talk about the impact of the extremes we have gone to protect people's health insurance. That I can't tell an OB-GYN that the woman he is treating is a drug addict. And there's probably a very high chance that she could be dead within 1 year of delivering the baby. I can't tell him or her that. There are no break the glass exceptions. And again, my timing could not be worse. Everyone is screaming about the loss of their privacy with all these social network stuff, and with all your purchasing is on Amazon is all over the place. But I think we have to have a mature conversation about protecting each other, that maybe we've gone too far in another direction in terms of health care, because you're not able to really manage care. And I can't tell you.
One step further. So in my job, I used to have a pretty good poker face, but occasionally I got myself in trouble when people would say things. And one of the times I got myself in trouble was, and I think the important thing to remember is a lot of the privacy stuff comes from a good place, right? So folks with a substance use disorder, it used to be and still is, the stigma associated with that is a big thing, right? So there are a bunch of people who worked very hard in Pennsylvania to try to keep all that information confidential for what it meant for folks. And it's better now. People understand it's a health condition like many others, and it's a chronic illness, but it's still that case. And when we were talking about folks, and Bill gave a great example, but the one that I got myself in trouble was the laws in Pennsylvania are more strict than the rest of the country. And it literally was, I had an advocate say that the laws are set up so that someone with a substance use disorder, she actually made the argument to me, they can't tell their doctor if they want to, they have a substance use disorder, because that's the way the privacy laws are written. To which my response was, you have to be effing kidding me, right? Which was not a very smart thing for me to say, and everyone jumped all over me. But it was a crazy thing, right? So I think to me, hopefully most people think that it's a plainly ridiculous thing to make an argument that an individual can't tell their doctor if they want to that they have a substance use disorder. Someone made it. But the thing that struck me after people jumped all over me for having the wrong answer was, those folks came from a place of they thought they were doing the right thing, right? They thought they were doing the thing, and they believed it fervently. And it would be easy to sort of dismiss that as, oh, that person's crazy, right? But I think part of unwinding all that and the frustration Bill has, and I think probably a lot of people in this room, is understanding why they're saying that, right? And the battles they have. And I guess, you asked a little while ago if I had something to do over again, I probably would have said, why do you feel that way? And do you want that person not to be well? Because the reason why they have a substance use disorder is they're an undiagnosed person with depression, and they're self-medicating with drugs and alcohol, right? That would have been a better way to do it than, are you effing kidding me? Which was what I said, which I regret, right? But to me, I think the key in sort of unraveling all that stuff is remembering that most people don't get up out of bed anymore and saying, I'm going to do something crazy that makes it harder for people to get health care. They have a reason for doing it. So a lot of times you have to ask why, and then maybe you can get to it. I don't know if I would have made any headway with that particular woman, but you never know.
Just to piggyback on the data conversation, I think if we did a better job of capturing data in real time across systems, it'll also really help with the storytelling. I mean, there's something really compelling about seeing a care utilization histogram go down after a point of intervention. that tells a story that you don't really have to explain in great detail. And it is something that policymakers and investors and insurance executives and providers can all understand intuitively. But it's very rare that we can actually illustrate the impact that programs like MANNA has in such clear terms. So I think thinking about how data can help tell a story too is an important thread that we should remember. We have probably time for one more question, and then I got to wrap it up. So right here.
Hi, I'm Mitchell Krieger. I'm a nonprofit consultant, mostly worked in the arts throughout my career. So the question of data and how data is used and how data is gathered is something that in the arts world we've been wrestling with a long time, because most of the data we use is about marketing. And in education programs within arts organizations, we do try to do some tracking of what's going on. But I guess my question is a really large question, which has to do with how can we be, when I say we, I mean all of our society, everybody who's involved with trying to get to positive outcomes, how can we be smarter about the way we gather data, the way we think about data? Is there somebody who is doing the 50,000 foot picture of how data should really be used to improve all of our organizations, all of our outcomes?
In the 90 seconds that we have left. But that's a great question. Are there examples that you can think of where people are innovating on this data question in a way that could have systemic impact and learnings for all of us who are doing this work?
I think that to a limited degree, the movement towards value-based contracting and value-based payments, where, for instance, states and the federal government pay based on the underlying acuity of a person's medical conditions, will drive providers and insurance companies to begin to collect this information, because otherwise they'll get paid less. I think that's driving people to do a better job documenting that I have diabetes, I have some other medical condition, because I'll get paid more and paid appropriately. I think that'll drive people towards that direction and that goal. But it's you have to give people the incentive, because most providers bill based on procedures, not based on diagnosis. So we disconnect. So, but I think we're ultimately going to get there. Not a great answer, but.
So I would just add to what Bill's saying is you measure what's important to you, right? And right now, the healthcare system measures outputs. It doesn't measure outcomes. So I think part of it is you have to get the healthcare system to measure outcomes, right? Because then, and that starts with payers paying for outcomes and getting folks aligned that way. I think there's a long way to go with that. I think the key, though, is always going to be, and I think Bill and Sue were sort of talking about it as well, as there's always this excuse of, well, the data isn't good enough, right? It's not precise enough to be able to do this. We don't know. We can't measure. The punchline is it's never going to be perfect, right? And for us, I think we have to get to a mindset where we can make decisions on data, based on data, but not understanding that it's never going to be perfect. But if it's good enough, that's enough to make the decision, right? So there's a little bit of faith there. So it's a weird thing where, data is a science and people look at the numbers, but there is a little bit of art to it and there's a little bit of faith there. And it warmed my heart to hear Bill say, I didn't care what the data was. He didn't 100% mean he didn't care what the data was, but he just knew that the data was going to prove him right. At the end of the day, he was willing to take that chance, but understanding that we all have to get to a place where good enough is enough to make that decision, because we can spend 100 years trying to perfect the data and we're never going to.
It's interesting that the for-profit world just occurred to me as we were having this conversation that they're doing this. I mean, Amazon was mentioned before. My God, I get, things tailored to me because I use Amazon a lot. And so they're gathering the data and acting on it.
Yeah, and then sometimes they're good and sometimes they're not, right? So on my Netflix account, I watched that Ted Bundy movie, and now they think I love serial killers, and all I get is, I get movies for serial killers, and I'm like, I'm interested in other things, guys. So, so sometimes it works, but it doesn't work perfectly all the time.
Cautionary tale.
Yeah.
Sue.
I just wanted to quickly add to that is that I think, certainly with the launch of the MANNA Institute, we're really teasing out the difference between scientific data and marketing data, right? And that, I'm always like, put that out there, get that out there. And our for-profit competitors, right? We go to these health conferences and they have these huge booths where things are packaged and they're referencing data that we publish, but they're marketing it in a much more sophisticated way. So I think as a community-based organization, we have to be thinking also, obviously research and scientific data and following the guidelines and the IRB and all that stuff, but also just getting some common sense, like information about our programs out there in a much more sophisticated marketing way.
And I think that when I've seen, MANNA has a great video that I've seen many times as a board member and at many events, and it's a great video. It tells the emotional story, but there's one part that always is interesting to me is there's one part where they put the numbers up about reductions in hospitalizations, and it's just 3 numbers, right? And almost every time, no matter when that part comes up, there is spontaneous applause in the room. And I think the reason why is it's concrete. People understand what it is. You need the emotion, and that's a part of a sophisticated message. But those 3 bullets, you get spontaneous applause from people who are watching the video, who may be eating dinner at the time they're watching the video or doing a whole bunch of other stuff, right? Yeah. When the video comes out.
David, you had a comment?
Just really quickly, I wish we had more time to have this conversation because these are all great questions. And if you are interested in digging deeper into those issues around data or how you get started or how you make a case to payers and funders or how you've been able to tell the story in a compelling way or how you've been able to link with other service providers to sort of be the people who produce better health and better value in your communities. It's all in that book, and it's available to you for free. That's your tax dollars at work, and as many copies as you'd like. So if you'd like to take it back to your organizations or share it with friends, just go to the website investinresults.org. You're welcome to order as many copies as you like.
So I think there's an elegance to this social determinants of health sort of discussion and this relationship between the social sector and the healthcare system. And I think there are many, many, many great examples out there of how to do this effectively, but not as many as you would expect. And I think it's not because we don't have good ideas, and I think it's not because we don't have great programs that are producing enormous value. I think it comes down to leadership. And I just want to thank this panel because I think that leadership was absolutely on display for this discussion. I think it is the secret sauce that gets partnerships like this over the finish line. So this is truly special. Thank you for participating today. Please join me in thanking the panelists. And let's one more round of applause. Let's give Bill a send off.